implementing, you are implementing, or you may do so in the future. So I think if we can advance the slide. Okay, so I'm going to talk a little bit. It's been very interesting hearing what everybody's said so far. So I think it's really important because historically, a lot of what has happened in healthcare was you had physical health and then mental health was clear over here. And so like you'd ask someone when you treat a patient, they're like, yeah, I treat diabetes, I treat hypertension, I treat dyslipidemia. And I'd be like, so what do you do about mental health or depression? And they'd be like, oh, we don't do that. We refer that out. And so that's really the old way of thinking about mental health. Really the way to think about it today is it's just part of all of the chronic disease management that a pharmacist can do. And I think it was really interesting. I think it was Alex who talked about we have like this oversupply of pharmacists, and then others mentioned we have a deficit in other types of providers. Absolutely the same in behavioral health. We have shortages in psychiatry. They've really increased their residency training spots for psychiatrists. But we still don't have enough. We don't have enough psychiatric nurse practitioners or psychiatric physician assistants. And then I'm going to say something that sounds really strange in the field of pharmacy. We don't have enough psychiatric pharmacists. That's one area of pharmacists that the demand way outweighs the supply. There's probably less than 1,500 board certified psychiatric pharmacists. And we only have about 100 PGY2 psychiatric pharmacy residency slots. So there's no way that just the psychiatric pharmacists are going to be able to treat the tens of millions of people who have psychiatric conditions. So this is where community pharmacists have a huge opportunity, and also in AmCare, to really help address those needs. And I'll tell you, patients want to see you. When I was at Arizona, I used to be on the acute inpatient psychiatry unit as my clinical practice site, and I would do med groups of patients. And part of that was telling them what to do if they ran into medication problems when they got discharged. And so I'd be like, so do you have a community pharmacist you talk to? And about half of them would be like, oh, I love my pharmacist. I love talking to them. They're so helpful. They answer questions. And the other half, they were like, wow, I've never thought about that I can talk to my pharmacist. So patients really want to talk to you too. For the Psychiatry Collaborative, we ran a patient and patient advocate group. Same response. We love our community pharmacists. We want them really involved in our care. So it's a win-win. It's filling a need and the patients really want to see you. So we'll advance the slide. Okay, so what are the conditions that you should be treating in the community or AmCare or non-psychiatric settings? So everything on this slide. So where this came from is, if you're familiar with the American College of Clinical Pharmacists Pharmacotherapy Toolkit, it's used a lot by a lot of schools of pharmacy to develop curriculum and determine what emphasis they place in their therapeutics curriculum. And so these are all tier 1 topics. And the definition of a tier 1 topic is in that box. So students should be able to provide collaborative patient-centered care upon graduation and licensure without additional training and experience. So this means all community pharmacists, whether they had residency training or not, should be able to treat these particular disease states. So alcohol use disorder, including alcohol withdrawal, anxiety disorders. Now you'll notice there's 2 that aren't there because they aren't technically anxiety disorders anymore. And that's obsessive compulsive disorder, which can be really tricky to treat and difficult to treat. And also post-traumatic stress disorder. Those actually fall more in the realm of specialists. Depressive disorders includes major depressive disorder and some of the other ones that you may not be as familiar with. Insomnia, that's a pretty common complaint that patients have. And then opioid use disorder and tobacco and nicotine use disorder, including smoking cessation. So this should be in the toolkit of every single pharmacist out there. And that's really, so going back to that board certified psychiatric pharmacist, Even if you're able to get one of those, there's no way they're going to meet all the need. So you're going to want your psychiatric pharmacist treating some of those higher level, more complex conditions. And you want all of your non-psychiatric specialists to be able to manage these disease states at a minimum. So we'll go to our next slide. Now, when to triage and refer, because that's a really important thing to know in the community setting, is when should I be doing it and when is it really probably beyond my training or my scope of expertise. Anything that's a treatment resistant or refractory, or when patients have severe symptoms. So I saw someone mention they're using the PHQ-9 as part of their process. So if a patient was screened to have severe symptoms, that's a patient who should be screened out to a psychiatric specialist, whether it's a pharmacist, a psychiatrist, whatnot. Treatment resistant and refractory, it's really easy to remember in psychiatry. For most disease states in psychiatry, it's failure of an adequate trial of 2 medications will then qualify someone as treatment resistant or refractory. And that doesn't mean they had adverse effects. It means they actually failed because of the effectiveness. High complexity psychiatric disorders, those are disorders that typically fall under serious mental illness. So things like schizophrenia, bipolar disorder, and that's typically because they need more of that whole behavioral health team approach to have the most success. Non-pharmacologic treatment desired by the patient. Now, it depends what they're asking for. If it's something that you could do, like for example, a patient may ask you about, is there an app I can use for mindfulness? Well, that falls within the realm of a pharmacist. But if they want to do something like cognitive behavioral therapy, or one of the therapies where you need that type of education and training to provide, those are patients you're going to refer out. Although you may still see them because they may want to do medication and therapy. And then obviously any acute situations, it's really important that whenever you have a patient expressing suicidal ideation with intent, means, and plans, if they'd have homicidal ideation, those need to be referred out. And usually that's when you can make that connection to the crisis line or to crisis teams. We'll go to the next slide. Okay, so a lot of times when people are starting to think about, okay, so how do I integrate mental health and psychiatry into my current practice, because that's not what I do. Like, it seems really daunting. It's kind of a huge step. So let's talk about some ways to think about that. So we'll go to the next slide. So one thing that I think is really important to think about, and this may differ depending on your particular health system or health plan, but one thing you can think about is what are core behavioral health measures that are out there. And some of the ones that I'm going to talk about today are from the Centers for Medicare and Medicaid Services. And so they have 18 behavioral health measures, and they're currently voluntary reporting at this moment. And there's 13 adult and 5 child. So if you do have child patients that you see or manage, you also want to take a look at those. And so these are measures that were developed by a variety of organizations, some of the ones you've probably already heard of that are listed there. And so the core measures are what are used to measure and evaluate progress toward improvement. And I think it's always a good idea, if you're not sure where you want to start, or maybe you're not quite sure what the landscape is to take a look at these quality measures and see how they fit into your current health system or health plan. And I provided you the link there to go look at these. So we'll go to the next slide. Okay, so I'm going to give you some tips on how you can just integrate some of this seamlessly or fairly seamlessly into some of what you're currently already doing. So it's not going to be a huge change in your practice. So there's some related to diabetes and schizophrenia and serious mental illness. So remember I said that for the psychiatric piece, you're going to have to refer the patients out. They're probably going to have schizophrenia, other serious mental illnesses managed by a behavioral health team specifically, but they still need care for diabetes. And so one is screening if there's an antipsychotic medication plus a diagnosis of schizophrenia or bipolar disorder. Because one thing that's important to know is persons with mental health disorders and with serious mental illness like schizophrenia, their primary cause of death is not suicide, it's not accidents or other things you think it is actually cardiovascular disease. And so these are patients who end up in the hospital because they have unmanaged diabetes. And so I think that would be pretty easy to see. It's pretty easy to see if someone's on an antipsychotic medication, or you may have the diagnoses as well. Now, just remember, antipsychotics are used for other things too. For example, they could be an adjunct for treatment of major depressive disorder, or used for other purposes. But, antipsychotic medications don't just cause metabolic issues in patients with schizophrenia or bipolar disorder. So if you actually look at all your patients with antipsychotic medication, if that's easier for you, that would work, because regardless of the diagnosis. Then treating patients who have diabetes, who have a hemoglobin greater than 9% and have serious mental illness. Because once again, those are going to be the patients who are going to end up having adverse health outcomes. So one tip with this one too, if you do have someone who has a serious mental illness, it's really important to make sure that they're receiving adequate treatment for that diagnosis, whatever it is. So you want to be in contact with their behavioral health team, because if their mental illness is not treated, they're not going to adhere. They're not going to be able to do what you're asking them to do to get their hemoglobin A1C lowered as well. So that's where you really have to work back with the team. Someone mentioned also thinking about looking at adherence for patients with mental health issues. And that's another one of these measures. It's adherence to those antipsychotics, again, for patients with schizophrenia. Steve mentioned the plan that is looking for pharmacists to administer the LAIs. And so that's a great way to help with adherence for patients who are using antipsychotic medication. But you can also do that for patients who are on oral medication. Sometimes I think people may not realize that when you have schizophrenia, it also involves cognitive symptoms. So a patient may want to take their medication, but they may have trouble remembering that they're supposed to take it. So it may not just be the symptoms you typically think of that are interfering with the ability for patients to be adherent. Antidepressant medication management, this is a huge one in the community. I used to see all the time, patients would come in with depression. I'd ask them what their medication dose was on their antidepressant, and they're like, sertraline 25 milligrams. I'm like, well, how long have you been on that? 2 months? I'm like, oh, that's an easy fix. And that happens all the time. So really be on the lookout for those subtherapeutic doses of antidepressants. When you see that, don't just assume that the patient's undertreated. You can use a PHQ-9 and see where they currently fall. But I think that's one of the easy things to look at. Now, the other thing to keep in mind is just because someone has a diagnosis of depression, it doesn't mean they have to take medication, because if they have mild to moderate depression, they could be receiving therapy. So you want to ask them about that and see, are they seeking therapy? What kind of therapy is it? And I'll tell you, most patients won't know it's cognitive behavioral therapy or not, because therapists don't always it's kind of complicated, but they may be doing that as part of other therapies too. So you can ask the patient, so what kind of things does your therapist have you work on? And if it sounds like CBT, even if the patient doesn't say they're getting CBT, they're probably getting CBT. For the substance use disorders, I'm not going to go into great detail on that. I don't want to steal David's thunder in just a little bit, because he's going to talk more about that. But if substance use is an issue that you're identifying in your systems, please note that there's definitely measures. And I think all of these are things that could easily be worked into some of your existing workflow, or when you're already providing CMM. And so I think these are just, in some cases, pretty low-hanging fruit to start with, if you really want to just kind of start diving in there and slowly kind of working some of the behavioral health into your already established practice. We'll go to the next slide. Okay, so I told you you're going to have to talk to each other, and hopefully we'll be able to break our participants on Zoom into breakout rooms for about 5 minutes. I'd like you, if you're already doing something, I heard some of this from our earlier presenters, I want you to share that with someone else who you haven't really talked much to. Might be a little challenging in this room, for example. And then go back one slide. So we can see what you do if you haven't done that yet. While we're moving back to the other slide, if you haven't done anything yet, that's okay. But maybe you could talk with your partner about something that you're thinking that you might want to do that maybe kind of clicked with you as I was talking about it. So go ahead, it's very short, just 5 minutes, just chat with each other. And then I'll ask a couple people to share what either they're doing or what they're thinking sounds interesting for their particular setting. And if we can, I'm not sure if we can get the slide back, but once again, something you're currently doing in behavioral health or something you'd like to do. Red button. It's not working. Oh, there, backspace. Oops. Oh, there we go. All right, there we go. Okay, so very quick, just quick discussion. I would say go ahead and do that 1 minute warning where they start coming back. Oh, that'll be great. All right, so we're going to start wrapping up and let people come back. And I know you didn't have too much time to chat, but hopefully this helped you start stimulating some of this conversation about what to do. So it looks like Steve has a microphone for the audience. So if you are on Zoom, go ahead and we're going to show the chat. We're going to share the chat so everyone can see it in the room too. So if you're on Zoom, go ahead and enter into the chat what is an idea, something you're doing, or something that you're thinking about implementing, so everyone can see that as you enter them. But we'll go around and have a couple of people share in the room while we're waiting, because I know it takes a while for people to start typing. So who would like to start? Or if not, I think Steve's just going to give the microphone to someone too. And if you're just coming back from the breakout room, go ahead and type in the chat. We're going to show the chat. If Lisa, if you can share the chat again, so people can see ideas that are coming through the chat while we talk in person too. Okay.
Hi. So we're from Riverside University Health System. We have a medical center, and also we have 12 FQHCs outside. So currently we do have a psych pharmacist. We also have a psych unit, but basically we have a psych pharmacist who will go to clinic. So the psych pharmacist will manage the depression patients, and then they go to clinic 1 day a week, and then they work closely with the behavioral health team. So we also have a behavioral health team who, like we have a psychologist there. So they work closely with them. They provide education or titration of medications for all our patients. And they also do close phone follow-up. So that's what we are doing at our facility.
Excellent. So you're one of the lucky ones who has the psych pharmacist. So that's great. Not everyone gets to have one. They're in short supply these days. Do we have anything in the chat yet? Oh. As I step away from the mic.
Hello.
Hi.
My name is Isabella, and this is our pharmacist, Stephen. And we're from ABC Pharmacy. We're a small chain of 15 pharmacies in mainly San Bernardino County and a little Orange County. And our location, specifically in Riverside, gives a lot of the long-acting injectables for psych. So we inherited those patients from our next door neighbor, which is a psych clinic in San Bernardino County. Ever since COVID, somehow they thought it was easier for them to get it in our pharmacy. So we've taken it upon ourselves to learn more about psych and see how we can service their needs by asking them about the metabolic syndrome, keeping up to them how they're actually doing in their quality of care. And also recently, because we get a lot of drug reps in the pharmacy, talking about Ingrezza or Austedo and evaluating the Parkinsonism, and also like if it's just going into tardive, a bad area of tardive dyskinesia.
Great. And that definitely ties back into the whole adherence to antipsychotics for persons with schizophrenia. So that's a great outcome you'll be able to track too. Excellent.
Lisa, do you want me to read from the chat?
Unless we have someone else from the room who would like to speak. Yeah, let's go ahead and just maybe.
You want to read one? Jessica Kim, it's typically if our asthma COPD patients share that they have anxiety and are not on any anxiety medications, we discuss with them starting with hydroxyzine palmate, sorry, I butchered that, especially since they have allergies. We ask them if they're open to trying this out as a dual indication. A lot of them are open to it.
Okay, so identifying that a person has anxiety and then looking at hydroxyzine. So one thing with that I'd recommend is that's a great opportunity for the pharmacist to ask more questions about the symptoms of the anxiety too, because you could use hydroxyzine if it's as a PRN for short term, but if you have a patient who has ongoing anxiety that's interfering with their life activities, like their ability to work, to interact with others, then that would be a great opportunity for the pharmacist to also talk with them about starting like an SSRI or an SNRI potentially. So that's really a good place to be able to intervene. And for the rest of them, I keep putting them into the chat because the audience, that way the audience on Zoom can read it and in our room. But I think I need to get off the stage because it's time for a break. So thanks, everybody.
Thank you. Okay, Dr. Goldstone, thank you. That was fantastic. Really great information, not only that you shared, but the audience shared as well. You know, just an observation, we are seeing health systems turning to pharmacies as resources for care. So that was, I'm glad you shared that example with us. Super helpful. Now, what we're going to do over the next, I'd say, we'll give you about 3-4 minutes, somewhere around there. We're going to transition into breakouts. And so physically in this room, we're going to have breakouts in 2 different locations. We're going to be facilitating that in just a second. So I guess we can take 5 minutes total to do that. There on the screen, you can see 2 different links depending on which breakout you're going to be in. I'm trying to clear my screen. Technically, session 1 is so-called advanced. It's intended for the teams that are already participating in California Right Meds Collaborative, just because they are dealing with these patients now, where Dr. Goldstone would continue to talk about soft skills for pharmacists and working with mental health patients. Session 2 is intended, we call it beginner and intermediate, but for teams that have not been engaged in California Right Meds. This will be facilitated by Dr. Connie King. It'll focus on patient engagement and retention and medication management and other longitudinal programs. Quick introduction, Dr. King is a faculty member at the USC School of Pharmacy. She leads interprofessional education with our Kaiser Medical School partnership, and the other half of her time is spent in California Right Meds working with the LA County sites. She's had a pretty long career for being so young, practiced in, I think, every type of clinical practice you can in pharmacy, and